for, excuse me, for the, an assessment of what's going on in the clinical space at the moment with the panel that sits before you and with some of the folks in the audience. But I think I can give you some assessment of what's going on and what the interesting questions are in the TAVI space at the moment. I don't have any disclosures for this talk. If we can get the slides to advance, we'll be good. There we go. So maybe we could rephrase the title to something about interesting questions in TAVI, because that's really what we would like to talk about in terms of the results that we really can't wait for. So we could talk about new valves in the marketplace. We're going to have a new valve in the US in the coming year. We've had a long-standing discussion about durability. I think that discussion is going to come into clearer focus with some of the trials that I'll describe to you. It's interesting, we could talk about the economics of transcatheter valves. Remember, we're talking about taking, as Tavor it takes over more of the landscape, we're taking high net contribution margin cases off the table, literally out of the operating room, putting them in the cath lab or the hybrid OR, and that's something that as healthcare systems we're going to have to be able to deal with. Reducing complications, this is a tried and true topic of conversation. Jeff was just talking about it in terms of PVL, but we're interested in stroke rates. We saw the Sentinel device earlier, and in pacemaker rates as well. And it's interesting, now that we're getting into a different landscape where we have more devices that are accessible, we're actually on the cusp of being able to do, I think, a lot of things with multivalvular disease. So with that in mind, let me just give you a few takeaways from what's going on in the investigative world. Low surgical risk is definitely on the front burner. We'll be getting some interesting reports from Dr. Mack's partner trial and the Medtronic low risk trial that Dr. Reardon is involved in. Medtronic low risk is STS of less than 3. It is about 1,200 patients and with long-term follow-up. Similarly, partner 3 is about 1,200 patients, all transfemoral sapiens with 10-year follow-up, and that's an STS of less than 4. So these are really low-risk trials. UK TAVI trial is a little different. It's more of an all-comers trial looking at all available transcatheter valves in UK and all access points. That is a trial that has about 800 or 900 patients in it, and I think it will be sometime before we get results of this study. Notion 2 is another interesting trial, about 1,000 patients. Again, it's all valves, but only transfemoral access, and those are patients who have an STS less than 4 and are under the age of 75. So we're really heading towards a much lower risk landscape with younger patients where valve durability is going to come into play. So in these 4 trials combined, we have about 4,000 randomized patients. Between them, 5 to 10 years of follow-up. And the vast majority of these patients will see an STS less than 4 or less. And we're expecting reports from partner and Medtronic low risk at the next ACC meeting in the spring. So what do we hope these trials will tell us? It's interesting, you know, when we get the primary endpoints of these trials, partner is a 1-year endpoint and Medtronic low risk is a 2-year endpoint. That's not necessarily the most compelling part of the story to me. I think the most interesting parts of this will be the longer-term mortality. I think this data set will finally allow us to stop borrowing so heavily from the surgical valve literature when we talk to patients about long-term durability issues. And I think that we'll also gain some understanding of what structural valve deterioration looks like over the long term. In other words, how will these valves fail? We know they will fail. It's an issue of time. Will it be structural valve deterioration? Will it be non-structural valve deterioration in terms of patient prosthesis mismatch or PVL? Thrombosis, endocarditis, I think certainly endocarditis will be we hope, a relatively minor player in that scheme. Thrombosis, though, may not be. So the longer term and long-term imaging of these valves, I think, give us a much greater database to look at long-term issues. Jeff showed you some interesting data on minor PVL, which has been, and Samir has published on that as well. What will mild PVL look like over a 10-year follow-up period of time? We don't know that at the moment. I think we'll also get some interesting looks at what the long-term risks of thromboembolic events are, what's the long-term issues surrounding pacemaker implantation in this patient population. I think another topic that we should probably include in this is looking at earlier and more aggressive intervention with transcatheter valves. The early Tavor trial has started. It's based on the premise that we can mechanically unload the ventricle with or without, in the absence of symptoms. So there's a very high prevalence of severe aortic stenosis patients. If you start dredging your echo databases, you'll find severe aortic stenosis patients who do not have symptoms. And the question would be, if we intervene earlier in them, can we prevent end organ damage? There's some retrospective data. I'm showing you a long-term follow-up from a number of trials showing that, at least with surgical aortic valve replacement, there may be a signal that we have improvement in a combined endpoint. So this is not just mortality, it's rehospitalization, et cetera. This has led to the early Tavor trial. We're focusing on patients with asymptomatic severe aortic stenosis. They have to go through a screening stress test. For those patients who can't undergo that stress test, it's medical history only, which I think may add some variability to the patient population, but it's a one-to-one randomization to transfemoral TAVI versus the usual clinical surveillance. And it's a 2-year composite endpoint that you see before you. We've started enrollment in that trial, but it should be some time before we have results. We're also looking at earlier intervention in patients with moderate aortic stenosis and left ventricular dysfunction. These two issues, the issue of aortic stenosis and heart failure and LV dysfunction, commingle significantly in an elderly patient population, as you know. Clearly, we understand that heart failure patients have an impaired quality of life and increased mortality, and the goal of medical therapy is to unload the ventricle. The question would be, can we mechanically unload the ventricle in these patients and achieve some beneficial effect? If you look retrospectively at patient populations, this is from 4 academic institutions, a follow-up study looking at, rather a retrospective study looking at death, AVR, heart failure hospitalization. You can see, I don't know if you actually can see that very well, but at 4 years, the primary endpoint was 60%. So this is a patient population that has a relatively poor prognosis, and we hope that by intervening early, we may be able to improve their prognosis. So the Tavor onload trial is underway. It's 600 patients that are equally, or rather randomized 1-to-1 to Tavor versus medical therapy alone, and the primary endpoint is what you can see there: all-cause mortality, disabling stroke, and essentially cardiovascular hospitalization. I think the last major topic that I'd like to address with you is the issue of anticoagulant therapy after transcatheter valves. Anticoagulant therapy is an interesting landscape. We've used dual antiplatelet therapy because it was involved in all the pivotal clinical trials. Our understanding of the pathophysiology of any of this is relatively meager. So we'd like to maintain valve function. We are clearly aware that valve thrombus is a problem both in transcatheter valves and surgically implanted valves. So we want to maintain valve function and avoid thrombus. We also want to prevent thromboembolic events. We really don't understand whether this is necessarily a platelet-mediated problem or a thrombin-mediated problem. Together with these issues, we also have the underlying comorbidities of the patient population we're frequently dealing with. There's a high prevalence, as you know, of coronary disease and heart failure. and atrial fibrillation. So a lot of these patients have other needs from a thrombosis standpoint. It's also a patient population that has a relatively high bleeding risk. So if you look at this, it's a relatively complicated landscape in terms of what these trials look like. Some of the trials that you see before you have been completed. ART, for instance, has been completed looking at aspirin monotherapy versus dual antiplatelet therapy, suggesting that aspirin monotherapy actually may be better. I draw your attention to popular TAVI. This is a safety trial looking at aspirin versus dual antiplatelet therapy in patients who do not have any indication for oral anticoagulation, and in those who do, looking at a combined therapy of Plavix and a vitamin K antagonist versus vitamin K antagonist alone. I think the other, and frankly I think more interesting trials would be Galileo and Atlantis. Galileo is a little ahead, looking at rivaroxaban with aspirin versus dual antiplatelet alone. This trial is, I think, well positioned for us to be able to look at valve thrombosis over a significant period of time, and we should be getting those results, I think, in 19. So that is something to look forward to. The Atlantis trial is a little further behind, and it involves Eliquis versus aspirin or dual antiplatelet therapy. So in conclusion, I'd say we're clearly reaching into lower risk and younger patient cohorts to investigate really mainly the durability of transcatheter valves and longer term outcomes. If we have reasonable durability in these patient populations, look, we know we have a larger EOA and lower gradients over time. That was something that came out of the Notion 1 trial and other trials, frankly. So I think it will be interesting to see what our endpoints look like in this younger patient cohort. The early intervention with TAVI may benefit certain subgroups that we haven't really looked at before, specifically related to LV unloading. And those would be patients who are asymptomatic or those who have left ventricular dysfunction and heart failure. And lastly, I think we'll learn a lot about what antiplatelet and anticoagulant strategies and combinations thereof may give patients the best long-term outcome with freedom from valve thrombosis and thromboembolic events. Thank you very much.